Welcome to Health Hour, a session for you by Black doctors, hosted by the Caribbean and African Health Network. Ever sat in a doctor's office thinking, they just don't get it? Or search for health advice online, but you can't understand it? Felt unheard? You're not alone, and you found your solution with Health Hour. Every Saturday at 11 a.m., this is your space where Caribbean and African healthcare professionals speak about health with a focus on Black people. We tackle the topics that keep you up at night: mental health, chronic conditions, preventive care, sexual health, men's health, women's health, heart disease, and much more. All with the cultural context that matters, because our Black doctors understand the unique challenges we face. Here is what you can expect: real talk from doctors who look like you and get it, lived experience testimonies, practical advice, illness prevention and management tips, and a space of understanding without judgment. You also get to ask questions. Your questions drive the conversation. Health Hour, where community meets Black health expertise.
Good morning, everybody, and welcome to today's episode of Health Hour. My name is Dr. Falake Yusuf, and we've got the pleasure of an amazing doctor and eye surgeon, Dr. Evelyn Mensah. She's amazing on all fronts. As a surgeon, she's great, and also as an advocate of race issues and Black health. So you've got a treat today from Dr. Evelyn Mensah. So she's a consultant ophthalmologist and a workforce race and equality standards expert at the London Northwest University Healthcare NHS Trust. And she's also part of the medical workforce race and equality standards strategy groups. Dr. Evie leads ophthalmology and anti-racism initiatives globally, so not just in London, not just in the UK, globally, working towards equitable healthcare, and is a strong advocate for institutional courage. Dr. Evie is the president of the ophthalmology section of the Royal Society of Medicine. So welcome, Dr. Evie, to the call today, and I'll pass this over to you to go ahead.
Thank you so much, Falake, and thank you for everybody who is joining online, whether it's on LinkedIn, Facebook, YouTube, whatever. Thank you for your time this morning. Before I give you my talk, I would actually like to say up front that most of us will have heard the horrific news of the death by suicide of Professor Jason Arday. And for those of you who don't know who he is, Professor Arday was a Black academic at Cambridge. And very unfortunately, yesterday, he died by suicide after what I would describe as a digital modern day lynching, where they literally hounded him. So I would like to dedicate my talk to the memory of Professor Arday, and just to reiterate that organizations like CARN, the Caribbean and African Health Network, and this Health Hour is an initiative that I would describe as by us, for us. There is nobody that is actually going to save Black people in this country. We have to advocate for ourselves. We have to support each other. We have to be together. We have to act collectively, because when you act collectively, it's powerful, it protects you, it inspires you, and it informs you. So I hope that today this talk will address a lot of questions that people may have about cataracts and cataract surgery. And I'd encourage you to attend the Health Hour weekly for every single condition, so we Black people can be informed about everything. So let me just share my slides, and thank you for letting me say what I had to say. I've just shared my, oh my Lord. Here we go. Okay, All right. So my name is Evelyn Mensah. Because I'm a surgeon, I have the prefix. Surgeons in the UK, we're doctors, we're qualified doctors. We went to medical school. I went to St. Mary's Medical School, Imperial. We have, when we do our graduation qualifications, and I trained to be an eye surgeon, we then get the prefix Mr., Miss, or Mrs. And I am actually married, but I use my maiden name. So it can be a little bit confusing for everybody. I am a consultant eye surgeon working at London Northwest University Healthcare Trust. I work in a hospital called Central Middlesex Hospital, which is in Northwest London, and it serves the borough of Brent. And it's a very ethnically diverse borough. So I'd like to talk to you about cataract surgery. I'd like to help you understand what your eyes are, your options are, and ensure that you know that it is all about your choice. So the overview for today is I'll explain what a cataract actually is and why having a cataract does not automatically mean that you actually have to have surgery. How the decision about surgery is actually made, what actually happens before, during, and after cataract surgery, and what we have learned, or I have learned as a Black surgeon about the recovery of Black people after cataract surgery, and also questions that you should ask your eye care team and where to get support. So before we start, I always start my talks with a little bit of a quiz. I might need Follikel Natasha's help, because I think it's helpful for us to understand the anatomy in the eye. Don't say that I don't teach you anything. I am teaching you about the different parts of the eye. You can call yourselves ophthalmologists after this. So does anybody know, just type in the chat, what this structure at the front of the eye is? It's the clear window at the front of the eye labeled as number 1. Has anybody put anything in the chat? What the clear window at the front of the eye is?
We're still waiting for answers. Come on, guys. There's no wrong answers. I won't say your name, don't worry.
Okay, there's no answers.
We've not had anybody come in with an
No,
answer.
no answers. Okay. Well, it's the cornea. It's a clear window at the front of the eye. Does anybody know what the colored part of your eye is? The part of the eye which gives people their color. For us, it's mostly brown. Some people might have green eyes, greeny brown eyes. White people usually have blue eyes, but they can have green brown eyes. Anyone know what that structure is?
So we've got iris on here.
Fantastic. Gold star to that person. Now there's a gap in the middle of the iris. It looks dark. It's a hole in the middle of the iris, and it's where light comes through in the middle of the eye. Does anybody know what that is? Structure number 3. It's the gap in the middle.
We've got pupil, lens, somebody has said, cornea.
Fantastic, fantastic. Pupil is correct. Now, behind the iris is a structure. Give you a clue.
Lens, we've got the answer already.
Lens, exactly. This is where your lens sits. Any cloudiness of your lens is what's known as a cataract, and it's normally clear like a glass pebble. All right, so we're going back to the jelly at the back of the eye. The jelly inside the eye fills up 2/3 of your eye. Okay, it's called the vitreous gel. Then there's the light-sensitive layer that lines the back of your eye, a bit like the film in a camera. Light-sensitive layer, beginning with R.
Oh, I've got optic disc. I don't know whether that, optic
it lines. No,
retina,
no.
Yeah,
Retina. Perfect. Now, there's a part of the retina that you use to see things in fine, clear detail. So when you're reading, looking at the features of someone's face, it's that central part of the retina. There are 2 answers that people could potentially give. Anyone? I'll tell you. The fovea, and around it is the macula. That's the part. It's smaller than the size of a pinhead, but it's what's responsible for your clearest, finest vision. And then this structure that leaves the back of the eye, going from your eyeball to your brain, is, somebody said it already.
Optic nerve. Optic disc has already come. Yes.
Exactly. Both of those things. Fantastic. Everybody, you're all awake. Well done. All right. So what is an actual cataract? Well, your eye has got a natural lens. It's that blue structure there that just sits behind the colored part of your eye, the iris, as we just talked about. And normally your lens is crystal clear. It's like a glass pebble, and it helps light to focus onto the fovea, the center of the macula. It refracts the light, it bends the light to focus onto your center of your macula. And what a cataract is, it's literally clouding of your lens. Any pacification of your lens is a cataract. It could be small, like just a little bit of clouding, or it could be completely dense, or a bit in between. There are lots of different grades of cataracts and different descriptions. So it's not a growth. Most people think it's a growth or a film that grows over the surface of your eye. No, it's not that. I think the people are confused by something called a pterygium, but what it is just mistiness within the inside of your lens. So how do we actually develop cataracts? Well, age by far is the most commonest cause of cataracts, and cataracts start to develop from the age of 60 onwards. There are some people in whom cataracts may actually come on much earlier, such as people who are living with diabetes. They may get cataracts that come on a little bit earlier in their 40s or 50s. There are certain steroid medications, whether it be steroid tablets, or whether it's even maybe steroid cream that you might be using, or steroid drops in your eye that can actually induce cataract, or even having a previous eye injury, like a blunt injury, like a ball hitting the eye, or God forbid, somebody punching you in the eye. Later on down the years, you could develop a cataract. There are some surgical procedures that can actually induce cataracts going on a little bit quicker. For example, if you have a retinal detachment or a retinal tear and you have surgery at the back of the eye, that in itself, the chances of having a cataract from surgery at the back of the eye called a vitrectomy or a retinal detachment surgery is almost 100% within 2 years. There are other eye conditions such as glaucoma or uveitis, which is inflammation in the eye. Sometimes having uveitis, you're on steroid drops, that can actually induce cataract very quickly. And sometimes being very short-sighted can actually induce cataract onset a little bit earlier than usual. So how would you know that you've actually got cataract? Well, you can actually develop cataract in one or both eyes at the same time at different rates. Two sides of your body are never the same. Things are not developing exactly at the same rate. So what happens is your vision gradually comes misty, cloudy, or foggy. And sometimes if you wear glasses, it can feel as if your glasses might need a little bit of cleaning. So you might take your glasses off, clean them with your lens, but it's a very gradual process. I wouldn't say it's something that comes on very quickly. It may be quite early, and some people who are drivers may notice glare or dazzle from sunlight or headlights at nighttime, and they may suddenly find that all of a sudden it's very difficult for them to see when they're driving at light because of the glare that they get from sunlight or headlights from other cars at night. Colors may look less vibrant, particularly the color red. It's amazing after cataract surgery how many people tell me that they can suddenly now see the dirt that was in their house, or the colors of their curtains or whatever are not the color that they actually thought that they were. And also what happens with some people when you're developing cataracts is that it can induce you being short-sighted. It can simulate the effect of you actually being short-sighted. So people then notice that they actually have to change their glasses more often than usual. If you wear glasses, you should have an eye check every 2 years, but they then feel that after a couple of months or so, they feel as if their glasses need to be changed. And this GIF on the right is just simulating what normal vision likes, what early cataract is like, and then really as things get denser, what a moderate cataract is like and what it's like when you then have a very severe cataract advance and you can barely see the letters on the reading chart. So having cataract does not necessarily mean that you must have surgery. And I think this is the message that I'm really trying to get across to everybody, which was probably strange coming from somebody who is a surgeon. I don't do private practice. I used to, it just didn't agree with me. But so I've got nothing to gain by actually saying that you should or you shouldn't do it. I'm just telling you the truth. Just because you've got a cataract, it does not mean that you have to have surgery, all right? You need to look at other things and factors, which I will explain in a moment. It's not like, for example, if you have high blood pressure and just say it can't be controlled with diet and exercise, and you have to have the tablets to prevent yourself from having a stroke or whatever, that's you have to have, or even living with diabetes. And again, you can't control the blood sugar with diet or exercise, or you're type 1 diabetic and it's genetic, and you have to be on insulin or tablets. It's not that same situation. When somebody, an optician, an optometrist, an eye ophthalmologist, eye care professional says, you've got cataract, you have to have surgery, just pause and just ask some questions. All right. So surgery is actually one of 3 options. You could actually do nothing and just be monitored and be reviewed. And that is a valid choice if the cataract is not bothering you. For example, someone says to you, you've got cataract, you think, hang on a minute, I can watch the television, I can read my book, I can read my Bible, whatever it is, it's not bothering me. It doesn't affect me when I'm driving. As long as you're at the correct legal requirement for driving, you do not need to do anything. All right? You could adapt your situation. You might need new glasses. You might need your glasses updated. You might need brighter lighting. Magnifiers, you might need that, or better contrast. If you decided that you had cataract, but you don't want to have surgery, you're not a driver, you're not a danger to anybody, you're just going about your normal business and you understand you've got cataract and you just know that you just need to adapt your situations, it's a perfectly valid option. Surgery is when you actually have the cataract affecting your normal daily living activities. All right. So basically, you cannot see clearly to drive. You cannot see the text on the television. Things look blurred. You're finding it difficult to read. You're changing your glasses often, and you understand cataract and you want to have surgery, then surgery is the option for you. Remember, cataracts do not usually damage your eye permanently while you wait. There's no rush, it's not an emergency. All right. And there is no single right time that applies to absolutely everyone. Everyone talks about ripeness. That is a very old-fashioned term. That's a term that was used in the olden days when cataracts were so dense you could see the pacification through the pupil. You could see that someone had a white pupil. I wouldn't recommend that you wait until it gets to that level. So you don't have to wait to that level. You can have cataract surgery at any point if it is affecting your normal day-to-day activities. So when is surgery actually the right choice? Again, that question, is your blurred vision affecting your day-to-day life? It affects your ability to read your phone, cook safely, recognize faces, do the hobbies you enjoy, watch TV, get around. That is the time to think about cataract surgery. If cataracts stop you meeting the DVLA's vision standards, this is a situation where surgery is required, all right, for your safety and for the safety of everybody else on the road. If you're below the legal requirement for driving and you want to continue driving, then that would be the time to have a cataract operation. You could also have cataract and be at the level for driving and be safe, and that is absolutely fine too. So what is the legal requirement for driving? So if you go to the opticians, the optometrists, or if you're attending an eye clinic, there is usually a vision chart that you need to read the letters. There are the big letters at the top and the small letters at the bottom. Sometimes the letters on the chart are even smaller than this bottom row here. But what I've done, just to simplify things, is I've made the bottom row the 20 people call, lay people, when they talk about good vision, normal vision, we use the American term 20/20 vision. Have you got 20/20 vision? In the UK, we usually say 6/6 vision. This is something called the Snellen vision. All right, that means excellent vision. Sometimes people will use something called a logmar chart. So you might see the number 0.00. Basically, what I'm just trying to say is that is the normal vision line. Anything smaller than that is better than normal. Now, if you are a lorry driver and you drive buses, you need to be one line better than 20/20 or better than that. Your vision has to be Snellen 6/7.5, logmar 0.1. All right, you've got to be here where this purple line is or better to drive a lorry or to drive a bus. If you just drive a car, private like goods, just motorcycles, then actually it's 3 lines above. This line here, this brownish colored line here, is a 6/12 vision line. If you can read up to that line there, or even better, then you are safe for driving. If, for example, you're just reading the letters on this line here, you are below the legal requirement for driving. All right. Another point to mention is that you don't have to have good vision in both eyes to drive cars and motorcycles. You can have good vision in one eye, as long as your field of vision is not restricted. So there are some people who have something called a lazy eye, where they cannot read down to the bottom of the chart with one eye because it's a lazy eye. The medical term for that is amblyopic eye. As long as there's nothing wrong with their field of vision, and as long as one of their eyes, they can see this line, the 6/12 line or better, they are fine for driving. So making the decision about cataract surgery is actually your choice, and it should be made together with your clinician in the clinic. Our roles as clinicians are to examine your eyes and confirm, yes, you've got cataract, no, you've not got cataract, okay? Now, as an ophthalmologist, we have to check for other eye conditions. In our community and the Black community, there are other eye conditions that can affect the sight and therefore affect the level of vision that you may have in addition to cataract. Conditions such as glaucoma, where the pressure is high in the eye and it causes damage to the nerve at the back of the eye. That is a condition that can affect your field of vision, and that needs to be taken into consideration. So if you are having cataract surgery, sometimes the surgeon might want to deal with the cataract and the glaucoma at the same time with the same operation. You may be living with diabetes and you may have diabetic changes at the back of the eye. It is very important that the diabetic changes at the back of the eye are stable before you do a cataract operation, because cataract surgery can cause the diabetic changes to get worse. And so this has to be taken into consideration, and you should be informed about that. Other conditions that can limit your level of vision is the impact on the macula with an aging change called age-related macular degeneration. That affects your central vision. If you've got macular degeneration, some people shorten it with an acronym AMD, macular degeneration. That means that part of your vision may be because of cataract, Part of the vision may be because of the AMD. And we don't know when we do the surgery what percentage is from cataract and what percentage is from macular degeneration. It could be 50-50, it could be 60-40, it could be 70-30. So when you've got these other eye conditions, we have to give you what's known as a guarded prognosis, which means that we know there'll be some improvement, but it may be limited because of these other conditions in your eye. You need to be given an honest and realistic idea of what surgery can and cannot achieve for you. If you've got, for example, really bad damage of your optic nerve and you can't see very well, there is no amount of cataract surgery that is going to bring the function back to your optic nerve and allow you to see. You shouldn't have a cataract surgery in that situation. Your role is to tell us honestly how your vision is actually affecting your day-to-day activities. If it's not affecting it, tell them it's not affecting it. If it is affecting, then be honest about it. Say, I'm struggling to do this and I'm struggling to do that. Ask as many questions as you like. I have this saying, no question is a silly question. I say this to my resident doctors. I say this to my patients. No question is a silly question. And I can guarantee that when you're asking that question, there are other people that actually want to know what the answer to that question is. So then together, we can then decide with our support what is actually right for you. And I just want to reiterate this about no one, absolutely no one, should be pressured into surgery. Unfortunately, within this country, there are a lot of independent sector providers doing NHS cataracts. They're independent in private hospitals. They work together with the optometrists. And the optometrists, unfortunately, I have to say this, do sometimes preferentially send the patients to the independent sector providers rather to the hospital eye service, because they say that the waits are too long in the NHS in the hospitals. And I'm telling you that most of the times, most units do not have long waits. And as I said, cataract surgery is not an emergency. No one should make you pressured into having surgery. And no one should ever be refused a proper conversation about it. Now, you can decide for yourself whether or not you feel that you need to have cataract surgery. So NHS England have created a tool, and I'll get Natasha to put the link in the chat. It's a tool where it's called it's a free decision-making aid called Making a Decision About Cataracts. You can type it yourself. You can put those words in your browser, on the internet, on your phone, on your laptop, on your desktop computer. Just write Making a Decision About Cataracts. It's from NHS England. And when you click on the link, there's a PDF document. And it's actually useful to actually look at this before, during, or between consultations with your optometrist, your optician, or your eye specialist. And on this decision-making tool, what they do is they'll ask questions like, can you see well through both eyes, i.e. both eyes are open, yes or no? Are you affected by sunlight or glare while driving, yes or no? Are you able to fully enjoy watching television, reading, doing things, etc., etc., etc.? All right. If there are more yes answers, then adaptations may suit you well, or you might actually not need any surgery. If there are more no answers, then surgery may be worth discussing. Okay, so hopefully if anybody's here, or you've got a parent or a relative or anybody who's got cataracts, go through those questions with them yourself and determine whether there are more yeses or there are more nos. So what happens next if you decide that you want to have cataract surgery? Well, then a referral is made either by your optician, your optometrist, or your GP into a cataract clinic, usually in your local hospital eye service, when you are ready. When you come to the eye clinic, there'll be a lot of different things done that we say is a pre-operative assessment. you'll have your vision checked, you'll have measurements done on the eye to work out what lens implant we're going to put in your eye. We'll put drops in the eye to make the pupil big so we can see the lens. Remember, that's sitting behind your iris. Looking at your lens without an undilated pupil is not good practice. Making your pupil big is the difference between looking into a room with a keyhole or looking into a room with a door wide open. You can see much more. And then we can see the retina, we can see the optic nerve, we can see if there's any signs of glaucoma, we can see if there's any diabetic eye disease, we can see if there are any problems with the nerve, etc., etc., etc. And we might take some photographs and do a scan of the back of the eye. And then the doctor or healthcare professional working in the eye clinic will then examine you, have a discussion with you. If you then decide that you want to have cataract surgery, then they will go through the consent. It's informed consent. You don't sign a consent form unless you understand exactly what's going to happen. Now, usually when you have cataract surgery, you choose a lens implant that gives you either good vision in the distance without glasses, or you have good vision for reading. Now, most people choose to have distance vision, i.e. good vision in the distance without glasses, but then you have to put on a pair of glasses to read. Okay, so that's distance vision. And that's because in the NHS, we don't use multifocal lenses. We don't use lenses that give you good vision for the distance, middle, and near. So you either have good vision for the distance, or for some people who are very short-sighted and they like their glasses. They've had glasses since they were a child. They just take their glasses off to read. They want reading vision. So they then have no glasses for reading, and they're quite happy to put on their glasses to see in the distance. You're usually given a date for surgery, and waiting times can vary locally. If the waits are long, you can ask to join a cancellation list. So if there's a cancellation at short notice, then you can be given an earlier date. But most people on average should not have to wait longer than 18 weeks, the normal referral to treatment time. Most places, I have to say, have got waits that are 4 to 6 weeks. They're not very long in the NHS for cataract surgery. Now, what happens during surgery? So I'll be telling you about it, and I'll be playing a video of me doing a cataract operation. It's been speeded up. But basically, what happens on the day of surgery is that you'll come in, the nurses will put dilating drops in the eye to make your pupil big. Most cataract surgery is done under local anesthetic. You are awake for the operation. The local anesthetic is either numbing drops, which is what this operation, majority of the time, I actually just do cataract surgery with numbing drops and a bit of anesthetic inside the eye. I think it's a magical operation. I play a bit of music, really relaxed music, I take requests, all right? And that's the way that I normally do cataract surgery. Sometimes, if you cannot tolerate the light and if you cannot fixate on the light, then the operation has to be done with a numbing injection underneath the eyelid. I would say for me, 95% of the cataracts I do, I have 2 lists a week, 6 patients on each list, 12 a week, are done under just drops. I probably do a numbing injection maybe 5 times in a year, and that'll be for somebody who really cannot tolerate. Some people will be put to sleep, and I'll talk about that later. But you can see the lens implant has gone in, the cataract's been removed, and there are usually no stitches. It's a self-sealing wound. The procedure is done by a process known as phacoemulsification. Everybody thinks that it's a laser that does cataracts. It's a laser. People sometimes call it a laser phaco probe, but it's ultrasound that actually breaks up. Phaco is the Greek term for lens. Emulsification means it gets broken up into small bits, as you can see here in the video, broken up into tiny bits, and then it's sucked out. It's aspirated out. People say that they can sometimes see a light show, a bit psychedelic. When we operate, we use both hands, both eyes, and both feet. We've got an operating microscope. You're usually lying flat on your back with the drape covered over you. And I just want to pause this moment just to say that the laser phoco probe, and I know lots of people don't know it because nobody talks about it, was invented by a Black woman, a Black ophthalmologist in America called Patricia Bath. Professor Patricia Era Bath. She is the inventor of the phaco probe that's restored sight to everybody in the world. But you never hear her name because you know why? Because she's a Black woman, but I'm telling you about her now. And when I became president of the Royal Society of Medicine, the ophthalmology section, I did a little poem about her in my inauguration. I'm not going to go through the poem now, and I just took some slides from that talk just so that you could see who she was. She was actually the first African-American woman to actually have a patent. These are her patents that she had with her name at the top, Professor Bath. She had about 3 or 4 medical patents for the laser phaco probe. She was an amazing woman. She experienced a lot of racism and misogyny as a Black woman inventor. All right, because how dare she? All right. But she did a lot of work in underserved communities when it came to ophthalmology. I wish I could have actually met her because she's created a legacy and we should be truly grateful for her. Now, during the operation, you're lying, if it's a local anesthetic, you're lying on your back. There's a drape covered over you. There is usually drops, or if you have to, an injection. Some people might have sedation. It might be oral. It might be through a vein. Some people need to have a general anesthetic. People who have got really severe anxiety, claustrophobia, or are living with dementia, they may need to be put to sleep. But it's not that often. I think from the National Cataract data, it's probably less than 5% that undergo the procedure under general anaesthetic. Cataract surgery is the most commonest operation on the NHS, almost 700,000 operations each year in England. It's one of the safest operations, I would say, in modern medicine. And for the majority of time, patients have no serious complications. And it makes, honestly, it's one of those life-changing situations where you feel, as if you've done something really worthwhile, bringing sight, restoring sight to people. Now, you go home the same day, usually. Your vision's going to be a bit blurred because of the dilating drops, all right? So you shouldn't drive yourself, you 100% should not be driving yourself home after surgery, okay? For the first few days, your eye might just feel a little bit like sore, a bit uncomfortable, a bit gritty. You can just take some normal painkillers. Most of the time you don't. And I have to say, I always ask my patients after the operation immediately, did you feel any pain? They go, no. Some of them are scared. I have to tell you what, though, I'm telling you all of this. As a surgeon myself, I think as a patient, if I actually had to have cataract surgery, I am not sure that I would actually be a very good patient. I've been monitoring this and I've been monitoring that because I'm a bit OCD. Cataract surgeons, ophthalmologists, we are so OCD because we are operating within a very small space, 3 millimeter space. There is no room for error. So I don't know whether the profession chose us or we chose the profession. After a couple of days, your vision, you can definitely see the next day, even after an injection. After injection, you might have a little bit of double vision, but you'll be given a series of different drops. This is from my unit. A lovely medical student that came to my unit to do their elective around 10 years ago, Mohammed, he created this for me, and it makes it easy for us to tell the patients how often different drops need to go in. You normally have full healing in about 4 to 6 weeks' time, and you're normally seen in the clinic around that time. But while your eye is recovering, you should try not to rub your eye within the first 4 weeks. Don't go swimming in a public bath. Do have a bath and have a shower. Oh my goodness, don't listen to your little friends who say, no, you can't have a shower and you can't. You can wash your face. Just be gentle. Just close your eyes gently and just press very gentle. Please have a shower. Please wash your face. Don't not do that. Don't listen to your little friends who aren't even surgeons and tell you not to do it. Please do that. Washing your hair, I would recommend after a couple of weeks, just putting your hair back to get it washed, going to the hairdresser, stuff like that. It's very simple. Makeup maybe just avoid for the first couple of weeks or so. All right. And after 4 weeks or so, you can wear mascara and eye makeup. And I would avoid contact sports again during that. It's the first 4 weeks, I would say, is the most important time. Now, is cataract surgery safe? Yes. More than 94, 95% of people are happy with the results they get. The risks are very small. Nothing is 100%. Less than 1 in 200 people will have some form of visual loss because of the surgery, either because they've got other eye conditions like diabetes, glaucoma, macular degeneration, or there may be a little bit of swelling in the eye, or there may be a bit of inflammation that goes on a bit longer. Less than 1 in 500 have a serious loss of vision, but very rare complications called endophthalmitis, which is an infection, is very rare. It's 1 in 5,000, retinal detachment, 1 in 2,000. These are very, very, very rare complications. A common complication that can happen in people after cataract surgery, about 4 in 100, is something called posterior capsule pacification. And that can happen within a couple of months of the surgery, and it can be within 2 years, where there's sometimes people call it a secondary cataract, where there's clouding behind the lens implant. This is the original covering of the original lens, which is called the capsule, which is clear. It's like a sheet of like cling film, but in some people it can become cloudy. So it's the difference between looking through your living room window like a clear lens, or looking through like your bathroom window where it's all frosted. This is easily treated with laser in the clinic. It doesn't need another operation. You just zap a gap in it. It's called YAG laser posterior capsulotomy, and it's very common and easy to do. So what have I learned about the healing times after cataract surgery? Well, in my unit, we've just published this paper last year about inflammation after cataract surgery. We entitled it Persistent Anterior Uveitis, which means continuous inflammation after cataract surgery in a global majority population in Northwest London. So my patients are black, brown, and white, usually about a third of each. I noticed that for my black patients, the inflammation goes on so much longer than my white patients. And my brown patients, South Asian patients, it's in the middle. It's got nothing to do with the operation. It's to do with healing times. So if after cataract surgery, if after you've stopped the drops, you get a red, painful, light sensitive eye, that is inflammation. Rebound inflammation. You need to go back, they need to put you on more drops, and they need to go on for a little bit longer. Sometimes the drops need to be in your eye, the steroid drops, for up to about 3 to 6 months. In some of my patients, that's happened. Or even years. There are some patients that it's taken a couple of years before they've actually been able to come off the steroid drops because of the rebound inflammation that they get. So don't be upset or worried if you do have a longer healing period. That does happen. It's recognized internationally as well. So in summary, my bottom line is that cataracts are a natural part of aging. It's not necessarily a disease. It's nobody's fault unless there are other things that caused it. No one should be forced or pressurized into having surgery. You should have the surgery if you need it, because it's affecting your daily living activities or your ability to drive safely. the decision to have surgery should be shared between you. You're the professional, you the individual, you're the one that's using your eyes to see. All right. If your vision's clear, you don't need it. If your vision's blurred, you're not a driver. It's not affecting you too much. If you want to live in your world of blur, so be it. If you're blurred and you want to have surgery, then have the surgery. It's a safe operation. It's the commonest operation on the NHS. It's highly effective, especially when it's right for you. All right. So questions to ask your ophthalmologist, your eye care team. How much is my vision likely to improve with surgery? Do I have any other eye conditions that may limit my final vision? What type of anesthetic will I have? What will it feel like? How long is the recovery? When can I drive? When can I get back to normal activities? What are the risks specifically for me? What happens if I decide I want to wait or not have surgery at all? These are the questions to ask. You can get more support from the RNIB document, Understanding Cataracts. I'll get Natasha to put the link in the chat. All right. Or type in your browser, RNIB, Understanding Cataracts. There's a downloadable PDF document that tells you everything about cataracts. She's already put in the NHS shared decision-making tool. If you want more advice, you can go to Site Advice, Frequently Asked Questions. You can go to your GP optometrist. You can look at waiting times. And if you want to contact me, you can do it through Khan. You can send a message. I'm happy to answer. Thank you so much, everybody, for your attention and your time this morning. I hope you understood what I was trying to explain. I think we've got enough time for some questions now.
Thank you so much, Dr. Mensah. I learned a lot from that, because obviously as a GP, we refer, we see all these letters that come through from optometrists, and it just kind of flies over our head. Are we referring? Are we not referring? And it's so helpful to know that, because we see all these anxious patients and we're not quite sure what to say. I just refer them. I didn't know, we had that choice not to, unless the patient wants to. And I think for everybody else that is listening, that will be a good information to have as to when they go for their eye test and they've been told they have cataract. It's nothing to worry about. It's not a danger to the eyes. It's how it affects your quality of life. And I think that's the most important thing.
It's about quality. This is the message I really want to get across, because you know what? Sometimes for we as Black people, I recognize that a lot of Black people do not trust the healthcare professionals. They don't trust healthcare professionals because of the lies that we've been told. All right. So what I wanted to do today is to make sure people are informed. I think knowledge is power. All right. So as long as you're adequately informed, you know the right questions to ask, then you can make a more informed decision. I don't want to frighten people from having cataract surgery. It's my most favorite part of the week, actually, doing cataract surgery, but not for the right reasons, not just because you've actually got the cataract. You don't have to have it if you don't want to. That's what I'm trying to say. I'm probably a bit odd. I'm odd in that way because everybody wants to get them in,
That's fine. And somebody has said something exactly along that line. I had cataract surgery that was booked, and I said I wasn't ready when the appointment came in. I guess that's what she said, but the NHS ignored me. What do I do?
If she said that she's not ready, then she can request to see the ophthalmologist again and have a conversation. Use the use the shared decision-making tool from NHS England, and you can come in with your little sheet or whatever, and and you'll say, this is my shared decision tool from NHS England. These are my answers. Can we explain why I need to have cataract surgery? Take the power back into your hands as the individual. If you're not ready, you're not ready. If you're a driver, again, the caveats are driving. I think that is the only thing that I would, if somebody was a driver and they were below the legal requirement for driving, I wouldn't report them, but I would tell them, I would put it in their letter, you are below the legal requirement for driving. If you want to continue driving, then I'm sorry, the only option would be for you to have cataract surgery if glasses are not going to help. That would be the only reason I would insist. And if they then decided they actually didn't want to have it and they don't want to drive, then fine. But if they want to and they're below, I'm sorry, you have to have cataract surgery.
Thank you so much. And somebody said, you're a very good doctor. How do we contact you? And I think you've said that at the end of the slide. You can contact her through CAN. And I think Natasha's also put Dr. Mensah's LinkedIn as well in the chat. So you can do that as well. I think that's fine, Dr. Mensah. Is that okay?
Well, I think through CAN might be better.
Through CAN is better,
I'm
yeah.
going to be inundated.
Okay. No, through CAN is better. I agree.
So you
Because
try,
LinkedIn,
you don't
you get
want
so
to be
much.
bested, or
Yeah, yeah, yeah. No, that's perfect. That's fine. So through CAN, if you send your questions through CAN, and they can always reach out to Dr. Mensah on your behalf. Another question here. My mom is 76 and had cataract surgery on one eye, but keeps putting off the second. She's nervous because the first surgery didn't go well. The truth is, 6 months later, she's still on drops, red and blue drops, various times of the day. She's tired, feels
exactly.
misunderstood, and
So,
is
there, right now, that person, that mum, absolutely has got the prolonged recovery I was talking about. Yeah. In Black people, I am telling you this, and they won't tell you, you won't hear it anywhere else. There is nothing wrong with the operation. It's just for us, sometimes the recovery should be long. She absolutely should not have the second eye done until the first eye is fully recovered. I don't agree with people putting drops in both eyes. It's too much. All right. So have a conversation with, and if it's more than 6 months, the clinician should have done some blood tests to make sure that there are no other systemic things going on, like sarcoidosis. Sometimes people may actually have TB. All right. Most of the times, the treponemal antibodies, most of the time though, there is no systemic cause, and it's just the longer recovery black eyes. There's not been enough research looking into it. This is one of the research areas I think that there has to be in ophthalmology, is that why do Black people sometimes have a prolonged recovery and need the drops for a long time? Why is that? But don't lose heart. Just reassure her. Eventually it will settle down. But for some of us, it does take long.
Thank you. And then another question here. My dad does not like going to doctors. He's 82 and fairly healthy. I see a blue ring around his eyes, but that doesn't,
That's
is
not
that
cataract.
should I
No,
get checked? She's
no.
asking.
It's called arcus senilis. I don't like the word senilis. It's on, right. If you were there for the anatomy session, it's on the cornea. It's the cornea, the clear window at the front of the eye. It's like a white ring that can sometimes look grey or blue. It's called arcus senilis. It's just an aging change. Some people sometimes have it in that when they're young, and it's a hereditary thing. It's on the outside rim. It doesn't mean anything. It's just one of those things that just happens to be there. That is not cataract. So don't worry about it. It's part of him. Just leave him alone.
Absolutely. Thank you. And somebody's asking if they can have the slides, if that's okay.
I don't mind people having the slides.
Okay.
I can send them
and
as PDF. Yeah.
yeah, because another person said they missed DVLE slides as well. So I guess if they get the slides, they can always look up the DVLE.
Sorry
yeah.
to interject. It's always available on YouTube, so people can go back to the
Can
session.
watch back. Fantastic.
Okay.
Thank you so much. And I think I've covered all the questions, Natasha. Please check if I've missed anything.
There's a couple more that came from YouTube.
From YouTube. Okay, give me 1 second. I'll go back. What can you do? What can you do? I didn't get that one. What can you recommend? What
What,
can
to
you
prevent
do
cataracts?
when you had the first one wasn't effective? I think if they've had the first one that wasn't effective, can you write that again? Sorry. What can you do? You had the first one wasn't effective. I think it's so they've probably had one
What do they
cataract
mean
that
by
wasn't.
what do they mean that it wasn't effective? What does that mean? That's what I need to
That's all.
understand.
Yeah. What would you
Yeah.
would you recommend a second? I
It
don't.
depends what they mean by wasn't effective. What do they mean? Was there no improvement in vision? If there was no improvement, have you discussed this with your ophthalmologist? What was your vision at baseline? What was the improvement? Was there improvement of certain letters? Was there any other eye conditions? Was
Yeah.
there a problem after the operation? Did they get more inflammation? Did they get swelling at the back of the eye? Or maybe, and I have to say that sometimes you see these days, because we're doing cataract surgery earlier and earlier and earlier, if you're already near down the bottom of the chart, there's not very there's not very far to actually go. Do you see what I mean?
Yes.
So I just need to just have a little bit of more detail about what they mean by that.
Okay, and there's another question. Thank you, Dr. Mensah. Very informative. A family member recently had lens replacement on both eyes and were presented with different types of lens makers based on pricing. How do you choose? I'm guessing this is more of a private or non-NHS question. I don't know if they give them
I don't know what
options.
I mean, the thing is that I don't know what they mean by different lenses, but the thing is that sometimes when we do the measurements, which are called biometry, it's a calculation that determines what your prescription is going to be in your eye. And as I said, most people will have a lens implant power that will give you good vision in the distance without glasses. But when you do the measurements on two eyes, there may be a difference in the lens power. All right. It may be that it might be by like one lens might be 20.0, the other one might be 20.5, one eye may be 21, the other eye might that might not that doesn't really matter. Sometimes there can be different manufacturers, but the biometry calculation, the measurements should still give the same outcome. So I'm not entirely sure what they mean by that.
Thank you so much. And the person who asked about her mom having, probably inflammation has said thank you. She will try and advocate for her mom better.
Good,
Um,
good.
and there's another question. Is there any non-invasive ways of treating cataract that are suitable for Black and minority ethnic patients?
Listen, if I could invent that, I would be a wealthy woman. I would share my millions with all of you. It's a bit like stopping your hair going grey. It's an aging change. It's part of age. It's a bit like, getting wrinkles, although we don't crack, we don't get wrinkles, but it's like but your hair's still great. You dye, you do something about it, you dye it. And I wish that there is nothing you can really do about the progression of cataracts. Some people talk about UV light. Yes, wear a good pair of sunglasses, but if your eyes are, it's an aging change,
Thank you. It's part of life.
unfortunately.
Part of life.
Part of life. Yeah, so don't be wasting any money on no drops. There are no drops. There's no randomized control trial that I've seen that's prevented any cataracts. So don't waste your money on that.
Yeah.
Be
Absolutely.
informed. Yes. You look at the things I sent to you.
So there is one more question. I had cataract surgery and the vision did not improve. I had cataract and glaucoma. I'm struggling with blurry eyes. They recommended a
Right.
second surgery, but the first wasn't effective. I'm on eye drops daily, so fed up.
So basically, it's because of the glaucoma.
Absolutely.
Yeah. The other eye condition.
Cool.
I saw a
Thanks.
question about lutein.
Yes.
Lutein is good for your macula. I think it's very good to have anything that improves eye health. It doesn't stop cataracts, but lutein in the macula is good for macular health. Your kale, your broccoli, your highly colored vegetables, good for the eyes. And anyway, Miriam's here, and I'm sure she needs to
I
just
know.
tell
Thank you
everybody.
so much, Dr. Mensah, for
Yeah,
that very, very informative session. And there's been so much thank yous as well in the chat. As I said, even as a healthcare professional, I learned a lot. So
you're
thank you
very
so much. It's
welcome.
a pleasure
You're
to
very
meet you.
welcome.
Yeah, thank you so much. Thank you so much, Dr. Mensah and Dr. Folake. Thank you so much. I mean, myself, I use glasses and I've learned a lot myself. So thank you. Thank you so much. And for everyone that has asked questions, they were really, really engaging. Thank you for your answers and for literally pouring into us this morning. Thank you so much, Miss Evelyn. And I know most of us want the slide, like my colleague has mentioned, is on YouTube. So I would literally recommend that we go back to YouTube to listen and not just about getting to also listen to what was discussed. Yeah, because I will go back as well. Thank you once again. But before we go, please stay with me for a few more minutes. Yeah, it's a part where we're handing over our wonderful upcoming events in the coming weeks to yourself as our our family, yeah, following us. So I would share my slide and then I'll quickly go over um what we have in the coming weeks before we call it a day. Just a minute. Yeah, I hope you can see my slides. Yeah, can you see my slides? Anyone? Thumbs up? Anybody? Yeah. Thank you so much. Thank you so much. So, just like we had this very, very informative and insightful session, we are going to have another one next week. We're back again next week. And as you know, Health Hour runs for 50 weeks of the year. And next week, we're going to talk about something important, which is breastfeeding. You don't want to miss this one because it's right on time. We're starting the Black Breastfeeding Week. 25th of August. So it's a good way to start the week. So it's the only awareness week in the world dedicated specifically to Black maternal and infant health through breastfeeding. So you don't want to miss that. Black mothers start breastfeeding, less often, they stop it sooner, they're less likely to be properly supported when it gets, hard. So this is a very, very good forum to ask your questions, hear real life conversations, practical answers, I'm sure, just like the one we had today, are going to be given on the day. So please do not miss out on Saturday, the 22nd of August, 11 a.m., same time and same link as well. We'll also send out information. We're going to have Dr. Vaughn with us to take us through that session. So whether you're expecting, you're feeding right now, or you're the partner, you're the mother, you're the friend holding someone up, this session is for you. So to register, please email us at info@can.org.uk. So yeah, next up is our red carpets. Yes, so we're going to the month of October, the Saturday, the 24th of October, at the Manchester Deansgate Hotel. There's going to be a Black History Month recognition evening for this year. Is also called our annual gala. And it's also the highlight of our Cannes calendar. This is a black tie event. So awards will be given honoring the community champions that will carry us. Yeah, most of the likes of what we had today. So they're often, sometimes you're quiet, sometimes they're unpaid, sometimes they're unseen, but this is a dinner that brings them together. We're going to be networking as well with amazing guests, live cultural performances, an evening truly of excellence, celebrating all black people in the room. So it's going to be um a wonderful event. So think about the person in your life who never asked for recognition. So bring them, or better still, nominate them. So I'm sure our nominations are open already. So bring them, book a table, make the night, about celebrating our talent. So tickets are on sale already, and inquiries would go to our events@can.org.uk email. Next up, just before we go for the recognition evening, we are going to be opening our Black History Month with our Black History Month civic launch. So we're going to be having that on Thursday, the 24th of September in Manchester. So this is a movement where we have civic leaders, community organizations, cultural institutions, and members of the public come into one room and to open the month for Black History celebrations. So we're going to have live performances, the unveiling of the full month-long program celebrating Black History. So Black History Month belongs to all of us. So you are welcome. So if you want further details about the events, please contact us at bhm@can.org.uk. Okay, so next one is grants. Please pay attention to this one because you might have someone in the room or yourself, sitting and who has an idea that is just sitting in their notepads, that needs, an action to go forward. So here we have the community micro grant of up to £500, available for Black History Month 2026. And this is from CAN, the Race Equality Panel, and the Greater Manchester Combined Authority. So if you're a black-led group, if you're a grassroots collective, cultural organization, youth and intergenerational initiatives. So if you want to run an event, an activity, a project that celebrates and educates and more likely connect our communities, we want to fund it. So you need to, you don't need to be a big charity for you to get this. So you just need an idea and an application. So application closes at 12 noon on Friday, the 4th of September. So scan the QR code if you're interested or you know someone that is interested, or email us at bhm@can.org.uk. We're here to support your ideas and fund it as well. So yeah, this is important to all of us. This is the APPG call for evidence on cardiovascular disease. And if we do not know, we have high blood pressure is around 40%, more in the Black communities in the UK. So 40%, that's the gap. And behind the number are things like strokes, heart attacks, all of these, and people dying way earlier than normal. So all the all party parliamentary group on Black health wants to close this gap, and this is a call for evidence, open to everybody. So yes, it's not just for professionals. Yes, we want to hear from clinicians, commissioners, public health leads, and community organization. But more importantly, we want to hear from yourself. So if you have navigated cardiovascular care yourself, or worked it with someone you love, maybe your loved ones have gone through it, we want to understand where does the risk, of developing this, where does it go unseen, where does access break down, where does trusted care actually feel like, what does it feel like, and where does the system let people down? I mean, we know about this, but we need it. You are the lived experience, you have the answers, but Parliament needs it written down. So please scan the QR code and complete this call for evidence. We need your voice on this panel. So up next is our Windrush compensation scheme. Please, if this does not apply to you, you could share it with people that you know would benefit. So if you know anyone who has settled in the UK before 1988, it could be a parent, a grandparent, an uncle, a neighbor, and they are putting off, the most of them don't want to claim, the Windrush claim, because they think it's a lot of paperwork. Um, you should know that those drawbacks or hesitation is costing people what they are owed. So the government is ready to pay people back. So CAN has a free confidential advocate across, the UK, where we would explain the whole thing in plain language. We would help gather the evidence. We'll help you complete the forms. We'll also stand beside, anyone at every stage. So no costs, none at all. So this is what we want to give back to the community. So one conversation could literally change someone's life, and it might be a conversation you start today. So please get in touch with us. You could reach Christina at the phone number on your screen. You could reach Shola as well, or best still email us at advocacy@can.org.uk, or you could pass on this information to someone that you think would need it. So finally, we have our safe steps. We know that sexual health is far more than just testing. It's about being understood, being respected and supported. So without being judged, without any lecture whatsoever. So Safe Step, brings to us free, confidential sexual health services. And we're coming into the community. So across the Lambert area, this Southwark and Lewisham, we are testing, we're giving out condoms, we're giving out self-testing kits as well. We're also giving out advice. So we are coming to you into spaces that, feel very, very comfortable for you to come into us. So no judgment, no cost, just care, 100% care. So our helpline is open, and you can email us at advocacy@can.org.uk. So please help us spread the word. Thank you very much for spending your Saturday morning with us. And thank you to our speakers as well. You were amazing. And to everyone that have showed up, that have asked questions, that have stayed until now. We really appreciate this time. Do take care of yourself, take care of each other. We owe each other that. Please take care of each other and see you next Saturday. We'll be here and we hope to see you too. Thank you so much and enjoy the rest of your day.
Bye, everyone.
Bye.
And that's our time for today. Whether you joined us on Zoom, Facebook, LinkedIn, or YouTube, thank you for making the Health Hour part of your Saturday. We hope today's session gave you the right dose of health wisdom that you can share with your friends and family. When we share knowledge, we strengthen our entire community. Mark your calendar. Next Saturday, same time. Got a topic in mind? We want to hear from you at health@can.org.uk. Health Hour, hosted by the Caribbean and African Health Network.